Hello and welcome. My name is Donna Cryer, and I am the founder and CEO of the Global Liver Institute. And I have the honor of being your host of this episode of GLI Live today. As we have been bringing you issues and experts in liver health for the past year now. It's been such an exciting experience, and we thank you for everybody who has watched, who has listened, who have submitted questions and topics so that we know we are meeting your needs and providing you the information and education that is most useful and meaningful to you. Today, that's this guest and this topic certainly meets that criteria. We have with us Dr. Rotonya Carr. She is Associate Professor of Medicine at the University of Pennsylvania in the Division of Gastroenterology. And so she is an expert in many, many topics that are of interest to us all. But today we'll be really talking about and diving down deeper into the relationship between obesity as a driver of fatty liver disease and NASH, and the overall impact of obesity in liver health, as we've just come off of Obesity Care Week and so much activity on social media and in policy about providing whole person care for people who are living with obesity. We want to make sure that we fully understand how it impacts and in fact can create liver patients. So Dr. Carr, welcome.
Thank you so much.
Thank you. So tell us about yourself. I always love to hear the stories about how someone came to gastroenterology and the opportunity to thank them for focusing on us. So tell me about how you arrived at this point in your career and your decision to do this type of research and care.
Well, thank you for that question. And first, it's really a privilege to be here with you. I was just recounting for your audience when I first learned about GLI, and I was just starting faculty, and I remember being so excited that there was finally going to be a patient-facing organization in the space of liver disease in the way that this organization has been really focused on education for many different types of liver diseases. So thank you for the invitation. So I'm a hepatologist or a liver doctor. I'm at the University of Pennsylvania, as you mentioned, and I'm also a scientist. I have to say, I didn't think I was going to be any of those things when I started out in medical school. My original essay was about wanting to become an OB/GYN. So there you go. Um, Met a lot of people through my training, had some really amazing mentors, and ultimately came upon hepatology, and everything just really matched my interests. And I always loved liver disease and caring for patients who had chronic diseases. I love metabolism and physiology. And honestly, hepatology is all of those things. I decided pretty late to become a hepatologist. So my first career was 4 years as a general internal medicine doctor, as a National Health Service Corps scholar. And then I came back to Penn to do my GI fellowship, and I've stayed on faculty since that time. My clinic, I started and direct our liver metabolism and fatty liver program. So that's been operational for some years now. And the majority of patients I see either have non-alcoholic fatty liver disease, NAFLD, which we're going to be talking about today, or alcoholic liver disease. And my lab is really an extension of my clinical work. I consider it my playground because there are all these questions that come up. Patients are very smart, and I can go to my lab and try to answer those questions for them. And particularly, we are focused on what happens very early in liver disease, not focused on the advanced stages of liver disease, but in my clinic, I focus on prevention and early detection, and so too in my lab. That's what our focus is. And in particular, we look at why fat accumulates in the liver, which is the early manifestation of the liver disease in this condition. And why in some people who can have the same behaviors in terms of diet or alcohol overconsumption, for example, some people will get liver disease and other people won't. And in my case, mice, some mice will get disease and other mice won't. So that's really what my lab studies generally. And how I spend all of my time, which is about 80% in the research realm and about 20% in the clinical realm.
I think that's so fantastic to be able to have that loop between research and care, and not just going one direction or the other, but really reinforcing the other. As a patient for so many years, I um, have always hoped and recognized that sometimes that loop was broken between what we're learning and contributing in the clinic, both as clinicians and as patients, in the hopes that it's improving the experience for other patients. But that hasn't always happened, and so as we create more learning health systems and a better practice to research loop, you really are at the forefront of what I hoped is healthcare looks like, and the lines between research and care are blurred further in the future. You've also, having set up an integrated, fatty liver disease clinic, particularly with that research component, are very much at the forefront. It's one of the things that we're just calling for now in our U.S. NASH action plan, and advocating that more health systems, consider as a way to be able to, fully address all of the concurrent conditions that so often occur with patients with fatty liver disease and NASH. And so, tell us what it's been like to construct that clinic and to get the buy-in from your institution and your other colleagues in associated specialties.
Uh, again, great question. I have to say, honestly, when I decided to start this program, it was my first faculty position. We didn't have any investigators in my own division who were studying NAFLD, and there was some skepticism in the beginning that this was even going to be as important of a disease as we now know that it is. So I used my own resources, mostly time, in the beginning to just get the word out about this disease. I made the rounds throughout the institution, giving talks and educating, particularly my endocrinology colleagues, where I did my own basic research training and had established some relationships already, but just getting everyone mostly on board to understand that this is not only a liver disease. And that was a really big shift, I think. And now I have to say that we have quite a lot of energy around campus for this disease and institutional support, and many other researchers who are involved in this work on the basic side of research as well as on the clinical and translational side of research. So I think that we have certainly grown over the years that I've been at Penn, and I'm really looking forward to seeing what this next phase will be.
Well, thank you so much for that leadership and that advocacy, and it seems to me that your early training and your early path and direction in internal medicine, and clearly your distinguished fellowship in the American College of Physicians,
Thank you.
plays a role in your ability to be able to understand the linkages and explain them, to your colleagues in a way that, engages them, and allows them to buy into this. And so, some things that don't seem to be, initially part of the path make sense further down the road when you put all the pieces together.
Absolutely.
So, you made a very, interesting statement that I'd like to sort of delve into a little more deeply, that some people can have the same BMI or level of obesity without the same amount of fat accumulation in their liver, without progressing to NAFLD and NASH. We also know that there's such a thing as lean NASH, so people who have a lower BMI but do progress to fatty liver disease and NASH. And so can you tease out a little bit more about what those different patient characteristics look like, and how we are addressing those?
Absolutely. I think I would say the first phase of research in NAFLD, and I think this goes really for any disease that's being studied, is really focusing on the epidemiology and the clinical characteristics of patients who tend to get certain diseases. And so NAFLD was no different. The early literature and certainly has been really well established at this point, and not for debate at this time, demonstrate that the major characteristics of people who are at risk for NAFLD are those who have obesity, so BMI of over 30, those who are who have diabetes or insulin resistance, we call it pre-diabetes sometimes. Those who have metabolic syndrome, which is a constellation of symptoms that can also include uh, high cholesterol levels, high blood pressure, and we focused a lot on sort of figuring out who would be at risk based on those clinical traits. Now, in 2021, we've since been able to add to that knowledge. We now understand a lot more about what's happening on the cell level, the molecular level. We understand a lot more about how genetics even contribute to the risk of not only getting NAFLD, but also getting severe liver disease from NAFLD. That being said, we still don't have any point of care tools for me to use in my clinic and tell one patient or another patient that your liver disease is going to stay at an early stage while yours is going to progress. And that is really the holy grail right now. What is it exactly that causes the transition from fat accumulation
Mm-hmm.
to the more advanced stage of what we call NASH, which is inflammation or scarring, even cirrhosis and cancer. My lab, we think we have some clues. We think it's actually something that happens very early in people that causes a different kind of fat to accumulate in some people as compared with other people. But that is something that we are certainly testing. Um, so risk factors, genetic risk factors, even we thought we knew, are a handful of genes that were going to put people most at risk, and some of those have been really validated. But we recently just did another genetic study looking at NAFLD patients, and we found 70 more genes that we think are associated with risk. So we're learning more every day, but it's complicated. It's a combination of clinical traits, genetic traits,
Mm-hmm.
what's happening in someone's biology that we can't see by just looking at someone, and also environmental exposures. I don't think we put enough emphasis on that. We certainly, I think, all agree that diets that are high in carbohydrates, particularly the sugars, are really causing a lot of risk of this disease. So a lot more work being done in that area as well.
So, for the genomic research, I think there's such a great opportunity to, ensure that in NASH there is, um, a diversity of an inclusive approach to, to the genetic research that has been, lacking to date. I've had wonderful conversations with Dr. Charles Otimi at NIH and others, and even recently, involved in a rare disease diversity coalition, looking at the data underscoring many liver diseases and potential disparities. But if we haven't been included in diversity in genetic studies before, then we may be looking at sort of misleading information as to which genes are involved. And so, as we look at the genetic markers and drivers and environmental triggers of different genes for fatty liver disease and NASH, it's exciting being at this early stage of the field still to ensure that we are having a very inclusive approach to the genetic viewing of how this disease manifests and progresses. So.
That's critically important. One of the things that we are finding at Penn, we have opportunity to utilize the Veterans Association's Million Veterans Program, which is really very diverse group of patients. And we have to validate findings in other data sets to make sure that what we find is a real finding. But that is challenging because there really aren't many data sets across the world that have the diversity that we have, for example, in this data set. And you mentioned the UK biobank,
Mhm.
even with fatty liver, their percentage of people who have fatty liver is diagnosed, say, by imaging
Mhm.
is quite lower than what we see here in the
Mhm.
US. So it is really a challenge. And so I think the solution is to make sure that we're utilizing all of these
Mhm.
databases and trying to get as much information as we can on as many groups of people as possible.
I really appreciate that, and as we've had conversations with communities of color on past misuse of genetic information in medical studies, but making sure that there is the understanding that unless we are included in things from the All of Us research or other genetic studies, we can't really be sure that medicines work in us, and we may be missing out on innovations and treatments that work particularly well for us. And so I'm a big advocate, even before I married a geneticist, but more so
Yes.
afterwards in ensuring our inclusion in that type of research in addition to others. So perhaps that's an area of partnership moving forward.
Absolutely.
So uh, this has been, we've been partnering very well with our colleagues in the renal health space for National Kidney Month and recognizing World Kidney Day and National Diabetes Day are occurring. Um, Many patients don't understand that their liver health and their kidney health are very connected. And can you talk a little bit about how NASH and diabetes go, back and forth, and just other aspects of liver health and kidney health together?
Absolutely. Um, I want to take just a little bit of a step back
Mhm.
and just reminding your viewers, or maybe they're hearing it for the first time,
Mhm.
that what we're talking about here is a disease that impacts not only the liver, it impacts just about every organ in the body, NAFLD. And similar to obesity, just
Mhm.
about every organ in the body has impacts from obesity. With NAFL, there are effects on the brain, on the intestine, the pancreas, the liver, the adipose tissue. So it's what we call a systemic disease, and the kidney is no different. Obesity, I think, is one of the risk factors that ties NAFLD with renal disease. But we have also found in our own studies and also some published work that kidney disease or NAFLD is a predictor of kidney disease as well. And it's not a surprise because inflammation ultimately underlies both of these systemic diseases. We also know that something called insulin resistance or prediabetes, where your body is not really responding well to insulin in the normal way that it should, that has effects not only on the liver but also on the kidney. The kidney can even accumulate extra fat, and I don't think a lot of people
Oh.
know that that happens in the kidneys as well, and is thought to be one of the reasons why kidney disease happens in people who are obese, for example. And maybe it's one of the reasons that kidney disease is also associated with NAFLD. That has yet to be established. But yeah, they are definitely linked. And certainly when someone gets advanced liver disease from any reason, certainly from NAFLD, we see that the kidneys are definitely affected. The liver circulation is the majority of the circulation in the body, and when the liver has problems circulating blood volume, every organ suffers, and the kidneys are no different. So we see quite a bit of renal disease, kidney disease in people who have advanced stages of liver disease like
Mhm.
cirrhosis, or certainly to the point of even needing to be considered for transplantation. Um, but I think if we go more upstream for both of these to
Mhm.
obesity and focus on that, we can really make a dent in the risk for both of these diseases.
It seems to me that the essential elements of what you need to do for liver health and kidney health and heart health and even brain health are all aligned. And so, if it may be difficult for people to think that there is an entire, constellation of things that they need to do, it may make that seem like an insurmountable, just hurdle to leap over and integrate into their days. But if we really think that there's a common, set of some very, simple things, higher quality, carbs, choosing the right types of fats, eating more whole foods, where possible, depending on your digestive disease, of course. And, so I think that it's a common set of preventive measures for a constellation of conditions. And certainly, it's good advice for everyone, but you've also written on health disparities, and so tell us perhaps why it is even more important, or the issues are compounded for communities of color.
Yeah, we're certainly all, I think, as a world, and certainly here in the U.S., really attuned to this issue, particularly over the past year, where we were seeing the COVID-19 related health disparities manifest. And my colleagues and I, though, looked at health disparities in patients with NAFLD a few years ago, and also again recently this summer in relation to COVID. And the first was an exploration of racial and ethnic disparities in those people who are obese, and also in people who have NAFLD. And then this summer, I joined with colleagues across the country and what we call the Cold Consortium, and we really wanted to understand if the disparities we were seeing is related to Hispanics and non-Hispanic Blacks in this country related to COVID, if they also pertain to those who had chronic liver disease.
Mhm.
So in the first paper, when we reviewed the topic, looking at NAFLD and obesity broadly, we found that non-Hispanic Black women have the highest obesity prevalence, and then it's Hispanic women, and
Mhm.
then non-Hispanic white women. And then in men, it's a little bit different. Hispanics have the highest obesity prevalence, followed by non-Hispanic whites, and then
Mhm.
finally non-Hispanic Blacks. So we're seeing differences not only in relation to race and ethnicity, but also in relation to gender. In NAFLD, we find, and this has been corroborated over multiple studies now, the prevalence is highest among Hispanics, about 45%, and lowest among non-Hispanic Black individuals. So that's kind of a disconnect between obesity prevalence and NAFLD prevalence. And so those data really lead us to understand that perhaps it matters, one, how we define obesity, which we can
Mhm.
talk about another time, but also where the extra fat is
Mhm.
located in the body. And it seems that, for example, in non-Hispanic Blacks, the extra weight and in fat tends to be in areas that are what we call subcutaneous skin, in the thighs, for example,
Mhm.
not so much in the areas surrounding the organs, which we call visceral fat, and we think that maybe that is what's accounting for some of that biologic difference in how uh, fat causes inflammation in these diseases. Um, but then we saw that although non-Hispanic Blacks, for example, have less visceral fat, which tends to be sort of bad kind of fat,
Mm-hmm.
having higher rates of high blood pressure, higher rates of diabetes. And so, how do you explain that? And we think probably the answer does indeed lie in some of the social determinants of health that we are now, I think, beginning to understand play, if not as great a role, if not greater, if not a greater role, than as great a role. In the summer, we did see that in our own study. We looked at patients with liver disease who were infected with COVID,
Mm-hmm.
and found that in our study that Hispanic individuals had the highest risk, and non-Hispanic Blacks also had a disproportionately high risk of COVID, even though they don't really account for most of liver disease in this country, and linked it to things like housing and poverty and insurance status. So these factors, I think, we have to take with the seriousness that we take biologic factors. They're equally, if not more important.
So thick thighs don't kill, but stress does.
Yeah, yeah, exactly. Exactly.
As we've talked about issues of weight bias and how to communicate sort of the different, cultural expectations and and expressions around weight. I think that those conversations about what actually drives harm and poor outcomes, and being able to address those factors, and not be distracted by by things that don't actually impact health, and maintaining a healthy self identity along the way
Mhm.
too. I think
Right.
is important. As we try to engage patients and create a sense of confidence and self-efficacy in taking on, the important and impactful, behavioral changes that may be necessary, but for the right reasons and based on the right evidence. I think
Absolutely.
so. Um, your work has so many broad applications. How can we support it in policy? GLI has been very active in integrating liver health as public health in the various COVID legislation, and having conversations with CDC to prioritize liver health. In its COVID and non-COVID documents, they were very receptive to updating their diabetes information to include information on early stage NAFLD, and we applaud them for that. And of course, we've been talking with FDA. But from your view, both in the lab and in the clinic, talking with all the stakeholders involved, what types of policies can best support your work?
I would really like to see a shift more toward prevention and early detection. I think in certainly in hepatology, our community of researchers has been really instrumental in helping us understand and manage the end stage complications of disease. And um, looking at NAFLD alone, this is Dr. Yunosi, who's a worldwide expert on NAFLD, and has
Mhm.
really mapped out what we can expect the trajectory of this disease to be for the next decade. And it's worrisome. And we cannot get ahead of this disease by focusing only on the end stage complications. We have to go more proximal. In the US, it's 1 in 3 adults, 1 in 10 kids who has this disease. Um, we have to really get to the point of where our adult and pediatric hepatologists are really joining forces to start early with the kids, and hopefully prevent them from even needing our care as adult hepatologists. I do understand that it can be expensive to think about what this will take, because there are so many people who are impacted with this disease. But as most of the people who have this disease don't know they have it, in fact, uh, when someone comes to us with cirrhosis and they have a diagnosis of, 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 of NAFLD, the majority are actually learning about their NAFLD diagnosis at the time of their cirrhosis diagnosis. That to me is unacceptable, given that we have diagnostics that we can use in a screening preventative strategy. It is expensive, but I think it's more expensive to not do it because we're going to be flooded, quite frankly, with uh, patients who have advanced liver disease, and we're not going to be able to offer them a whole lot at that point. So that's what I would like to see in terms of policy. Focusing more on prevention and early screening.
Mhm.
Um, Europe is ahead of the U.S. in this regard. I would like to see the U.S. At the least adapt and adopt what the European Society has recommended in terms of screening for NAFLD, and really directing resources toward the total care of patients, including nutritionists, right, exercise physiologists for our children. Every patient with this disease should have access to a dietitian and not have to worry about whether their insurance will cover it or not, because that is the treatment for this. So that's really what I would like to see, and I'm encouraged to hear about the progress GLI has already made in this regard, and certainly would be happy to partner to help in whatever way that I can.
Thank you. Well, you've helped a lot today by laying out the priorities so clearly. We have been very excited that the American Academy of Pediatrics has joined the NASH Council, um, and that we can start to address the entire line from gestational diabetes and setting up children and later adults, of course, for NAFLD and NASH, and start addressing it even at that stage through pediatrics, teenagers and adults in a multifaceted way, including community, chronic disease prevention and screening efforts, all the way to things like, as you mentioned, the access to dietitians and nutritionists in things like the Medical Nutrition Equity Act. Um,
Mhm.
there are a lot of pieces to the puzzle, and I think that through our NASH action plan, we're helping the community see all the pieces and just asking everybody to claim one and move it forward, and then
Yes.
we'll all get there together. But you're absolutely right that the cost of doing nothing, the cost of waiting until people end up needing transplant or have liver cancer, is so much more than preventing it and addressing it early in a whole person and whole community way. So that's what we hope to do.
Great. Thank you.
Thank you, Dr. Carr, so much for this conversation today. For this episode in the future and for other episodes, you can reach us at globalliver.org and on Facebook and Twitter and Instagram. And please send us your questions and topics for next time. But thank you for your time today.